Welcome everyone to IDM Scholar Society Study Club. We're so excited for tonight's featured speaker, our guest speaker, Dr. Steve Carstensen. But before we get started, I just want to say hello, drop in where you're coming from. I see a lot of familiar names and faces. Say hi. I'm in Florida, so love for Dr. Steve to see where everybody's joining us. As he's more on the West Coast. It's early out there. He was just sharing with us as I'm in Florida. Hi, Holly. Holly just came in from Florida. And so a little late here. I got my coffee. Can't wait to sip on some hot coffee and learn tonight. So drop in there. Hello from Nebraska. Woo! Love it. Alicia, love seeing you come on in. Well, I just have to share with you, Dr. Steve, I'm going to call you tonight. You just had an amazing ADA symposium on sleep that you had up. And in fact, if the team Dr. Anhorn's team's here, they were there and they were raving about it. So I would love for you to tell us a little bit about that. Heard so many amazing things.
Oh, well, thank you very much, Lauren. Thank you, Dr. Anhorn. I'm glad you enjoyed that. This was our eighth meeting of the American Dental Association's Children's Airway Initiative. We began it in 2018 with a kickoff event, and we've had it every summer since then. And it just keeps getting better and better. Some of the speakers have been at several of them, but I mix it up a lot. And so I try and get different speakers for every year, different emphasis. This year was on communications because so many of us know a lot of stuff. But how do we translate that into what the parents can say yes to allow their children to see a different, how their families actually to see a different future that begins with how their children breathe at nighttime. And all my speakers were there to talk about what they can do to give the language, give the knowledge base, give the communication skills, give the listening, whatever the necessity is to get the word across into an action item. We had Dr. Hale from Houston, who has 5 offices, and she has honed her workflows, her strategies, her resources, her protocols. So everybody in the office understands what the mission is, what the values are, how to say it, what communicates the most effectively. We had Robert Lustig talking about nutrition and the value of eating proper foods to be able to grow the bone support. So we had all these wonderful speakers, pediatric dentists from Western Massachusetts and Dallas and Chicago, and we had an orthodontist, a physical therapist. We had all these wonderful contents given to the or lessons. I hate that word lessons. Um, Insights. There we go. Insights given to the people that are eager to learn in the room. All of whom are going to take that message back to their communities and improve their families in their practices' health. Because if we can talk to the parents are concerned about their kids breathing, they're concerned about health, they're thinking about long term, and what can we do to make sure those families are provided the right amount of information so they can choose wisely. And that's what we're about at the ADA's Children's Airway Initiative. That's what Dr. Wilkerson and you guys are about the wellness program up there. It's such a synergy, that we can see. Most of wellness is about, the adults and what can we do to improve adults. But, we can't separate that from what these people are doing in their youth and while they're littles. And so we talk to the adults, so they'll talk to the kids. We talk to the dentist there, so they can take the message to the whole family. And it's just wonderful how well we knit together what we're trying to do to help our communities. Thanks for letting me go on with that, Laura.
Oh, love it. It's so important. I think, sometimes I have people reach out and say, I didn't know you guys were doing this. So again, just want to say all the great things. Really, you bring so much to our community, just really a leader in oral systemic, especially with sleep. And with that, I'm going to turn over to Dr. Gina. Say hi, Dr. Gina, everyone. She's going to read your introduction, just as some of your huge accolades that you have brought to all of us to make dentistry really making a huge difference in dentistry.
Absolutely, Dr. Carstensen. What an honor for you to be with us tonight, and we look forward to hearing your lecture. And, Dr. Carstensen has been a leader in this space for so many years and an advocate, and he's very influential with the ADA. And of course, all of us probably know, but if not, I'll remind you that he was influential in the 2017 ADA policy statement that dentistry certainly were premier and obligated to screen for sleep. And before that, everyone was kind of trying to figure out in dentistry, I think, what to do with sleep because anyway. So he was influential and is still influential in the ADA, of course. So I want to read Dr. Carstensen's life mission because that says it best because he is and will continue to fulfill that mission. His life mission has been to increase awareness of sleep-related breathing disorders, raise clinical competence for anyone who wants to treat them, and advocate for legislative, regulatory, and professional changes in the field of dental sleep medicine. So he has, and he is, and he will continue to fulfill that life mission. And tonight is a perfect example as he's going to teach us so many things that will be valuable, I'm sure. Thank you, Dr. Carstensen, for being here, and take it away.
Well, thank you, Dr. Pritchard. I appreciate this. And shout out to my friend Robin Henderson from Washington State here. And goes to prove that you don't have to be in a metropolitan area to make a giant difference. Robin's in the tiniest little town possible out in eastern Washington, but she has an outsized influence on Washington's dentistry and the world, really, because she's also a regent for the American College of Dentists. So she does amazing things. And Dave McCarty's here. Dave and I just had a chance to do a presentation together about this very subject. And so I'm honored that Dave's choosing to spend his time to do this too, because he just kind of heard some of this stuff. So we'll have fun. And Dave, chime in anytime you want. So let's go with this. And naturally, how about that? Hang on, guys. We rehearsed the share and then the share is gone. So let's do this. I know why. I got this figured out. Here we go. Almost. Yeah.
Hi, Steve.
Yes, sir.
Hi, Mike McDevitt.
Well, hello. Oh, Mike.
How are you, my friend?
I'm very good. I am making sure my share works. Guys, Michael McDevitt, a periodontist, you know, you can't just call Michael McDevitt a periodontist. He's way more than a periodontist, but he's a periodontal mission guy. It's amazing. All right, so everything up on our screen here so far?
Yep.
All right. So we will go with this then. The topic for tonight is about how we can't just think of ourselves as one part of medicine. We're highly trained as dentists, dental professionals, dental hygienists, myofunctional therapists, all the things that we're highly trained to do. We're highly trained as in our specialties, like Dr. McDevitt is a periodontist. But from the first time I met him, I became more and more aware of how the oral cavity is not just limited to in its scope of impact on human health. Nothing's disconnected, but we're trained that way. And what we want to do is reduce those barriers so we can make sure that when we're talking to our patients, we can get the whole message. If one of the things we focus on is oral health and tooth health and gum health and jaw joint health, the things that we're trained the best on as dental professionals, unfortunately, that can also limit what we're able to hear, what we're able to see, what we're able to connect with our patients about. And there are some simple ways to break down those barriers, to enlarge what you see. Not going to be new information, or certainly that message isn't new to the audience that signs up for IDM, because that's how it's founded. That's where Dr. Wilkerson, Dr. Pritchard, and Laura founded it, based on the fact that we can't just limit our thinking to what we were initially trained as healthcare providers. And all of us on this screen have taken the time to learn more, to be curious, to expand our ability to see. And when we see more, we do more. And that's what's important about this. That's kind of the message we have tonight. I've been doing education in dentistry for a very long time, which means that lots of people have hired me to talk, which means lots of companies have hired me to talk, and organizations have hired me, and educational processes have hired me. So I've been paid by a lot of people to teach dentists and others about breathing and sleep and all those things. Doesn't mean I have any conflicts about that. It just means I've been paid by them to take the same message to their audience. I am currently the consultant to the American Dental Association for sleep-related breathing disorders, which I'm very, very happy about, not because I'm the consultant, but because there is a consultant, and they do pay attention to some of that. I'm sad to say the ADA is going through some very traumatic times right now. And so Dr. Wilkerson's program and my program at the ADA with wellness and with children's airway are iffy at this point, and we're both working very hard to make sure that we carry on that tradition at the American Dental Association. I've taught for different educational institutes. Industry reaches out and asks me my opinion, and sometimes they give me some compensation for that, but nothing you're going to hear tonight has anything to do with any of that. I'm highly biased towards the Pankey Institute and the AAPMD, and I am the chief dental editor of Dental Sleep Practice Magazine. So got lots of things like that. I've written, co-wrote a book, and I've contributed chapters to some other books. And so if you buy some stuff, every now and then a few dollars ends up in my pocket, but that's not why I'm teaching anybody anything these days. So there's that. So the coolest thing I found years and years ago in the fifth edition of the Principles and Practices of Sleep Medicine, giant book. Now it's in the seventh edition. It's two giant books. But in a chapter about how to help people use their CPAP machines to help them breathe at nighttime, Dr. Krieger wrote this phrase: high perceived benefit is the first and most important step on the road to therapeutic acceptance and utilization. And I realized when I read that sentence that what a powerful statement that is for anybody in healthcare who relies upon their patient to do something in their own benefit. We're not surgeons. Well, we are surgeons, but we don't, when we do surgery, when we take out a cavity and put in a filling, when we do an appendectomy, when we do heart surgery, we don't need the patients to cooperate other than saying yes. But when we ask people to maintain their periodontal health, when we ask people to put an oral appliance in to help them breathe at nighttime, when we ask them to improve their nasal hygiene so their nose function gets better, we rely on them to do that. And why would they do that? Why would they take the time to floss every night? They do it because they feel the benefit. They understand the value to themselves, not to us, to themselves. And so when we take the time to learn about our patient, when we want to find out why it is that they're seeking our care, what is going wrong for them, then we get windows into their perceived benefit. Dr. Pankey told us long ago to get to know our patients and before we start proposing what treatments are, because all of our patients, being unique individuals, have different motivations for what they want to do and how they want to live their lives and what's important to them. Some people have no interest whatsoever in fixing the snoring that bothers their bed partner. Other people have a high level of interest in getting that problem solved. But when we understand what benefit we're talking about, then we can begin to apply our knowledge. We can tell them what it is that we recommend for them because we know the work that we've got. And when we apply our knowledge to their benefit, this sentence comes to life. It says they, in fact, are more likely to accept the therapy and actually put it to work. And that's what makes a difference in our community health. And so keep this in mind whenever you're asking a patient to do something on their own behalf. Now, I contacted the Council on Dental Practice about these kind of things and about airway issues. And I told you that ADA is kind of in a big uproar right now and they're struggling. But when I talked to the chairman of the Council on Dental Practice recently, and I said airway and children and wellness and things, all the key words that I wanted to ask them about. They said this, well, yeah, we talk about some of these things, but we have a lot of other things on our plate, and we're looking at different parts of the workflow, we're different parts of medicine, and so we actually haven't done much with airway, children, breathing, any of those interactive areas for a while, and we're not sure how it's going to go in the future. So that was not the most encouraging conversation I ever had with the ADA, but the Council on Dental Practice did take my call. We did have that conversation, and I'm confident that we'll be able to get those good values into the 5 and 10 year goals because they really do acknowledge them. They have the policy statement after all. But when we consider our practices, when we think back to small picture, what is happening in our individual care of our patients, you always have to keep in mind there are two goals because there are always more than one expert in the room. If you're sitting with a patient, you have your expertise. You've studied this. You become qualified. You know your subject. You know your work, according to Dr. Pankey's language. But there's another expert in the room because you don't know what those values are. You don't know what their goals are. You don't know what the patient's done in the past. You don't know what they're willing to do in the future until you have the conversation. So that's what you discover about this. So that means there's always two experts in the room, but there's always two goals. Now, the scientists, the physicians of us, we have data that we collect because we want to make good scientific recommendations. So we gather data in the world of sleep medicine. We think about how many events did they stop breathing? What do their oxygen levels do? Is that going to be a problem for them? Is there a difference between moving air and a lot and moving air a little bit? Did it really result in a imbalance in how their brains are able to manage their physiology? What's going on here? What's all the numbers? What are all the disruptions to homeostasis that we understand have downstream implications? What can we do to quantify those? And that's important because if we just go by how do people feel, that's not enough. We have to have some data that we can measure from. That gives us a grounding in our scientific method. That gives us a grounding in what we've been trained to do as professionals. That gives us a T0 value and a T1 value. How do we know our equipment's working? How do we know our therapy is being utilized? We have to have numbers. Thankfully, it's getting easier and easier to get those numbers, and the definitions of those numbers are becoming better and better defined. Interestingly, we come up with new numbers like hypoxic burden, and that nobody really knows what to do with quite yet. But there's a lot of people studying that, and pretty soon it'll become one of the numbers that we can universally report across our healthcare teams for our patients' care. And we end up with a value system that we can say, oh, yeah, look what I did and look what happened. And so the um, health gets improved. Years ago, I read a book by Dr. Valerie Crabtree. She's a PhD, and she was talking about behavioral health for children with sleep apnea. And she said to ask how your patient is doing or what they're interested in this way. You ask them, what's going wrong for you because of your, in this case, diagnosis? If we have somebody diagnosed with a sleep apnea related breathing disorder, well, okay, but what's going wrong for you because of that? When I ask people, how can I help you? What do you want to treat? And they tell me, I want to treat my sleep apnea. I said, no, that's what we measure. What's wrong in your life because of the sleep apnea? What is bothering you about it? And they tell me their unique stories. For children, we don't get to do that near as much because they don't oftentimes report the same way that adults. And they do report interesting things like I don't sleep well and I can't behave well in school and language that they use uniquely about that. But if we filter their responses by what adults have been telling us for years, we're going to miss the story. So you have to be curious about that and keep asking the right kind of questions, which means you have to be a very good listener and you have to know how to ask questions. And that's something that is valuable in a dental practice, valued more so than in a medical practice because we have more time. We have more relationship with our patients generally than our medical colleagues get a chance to do. was talking to a cardiologist the other day, and he said that with most of the models that he's seeing, physicians are given 4 minutes to see their patients now. It used to be 7, which I thought was horrible. Now it's 4. Well, that's not trending in the right direction. Then also importantly, we have to help our families, our patients, identify goals. What is it that's going to be better for you when we fix this problem? If you apply the therapy that we recommend, if we get a chance to expand your palate, if we make an oral appliance that works well for you, if your CPAP is used every night, how will your life be better when that happens? That way we get a chance to have them articulate what they vision to be an improvement. When they come back and we need to reinforce behavior like using a CPAP or an oral appliance or whatever it is that we've asked them to do, then we can refer back to, well, you had this goal. One of your goals was to be able to go on a golf trip with your buddies without getting a lot of crap about your snoring. How's that going for you? Been able to go on a trip lately? So we can connect them with the goals that they share with us, and that reinforces that high perceived benefit. Now, I live and work in the area of Microsoft and Google. I have tons of data scientists, of programmers, of all these kind of smart people in my practice, and they really want to know the numbers. When I tell them that, oh yeah, you're better. You seem to be better because you told me this, and you told me that, and they say, well, how's my oxygen levels? What's my sleep score on my watch? How's my Snore Lab app telling me about snoring? And they want to know the numbers. And some people, they don't really care about the numbers. They just want to feel better. They want their life to be better. And that's part of getting to know our patients. How do we satisfy whatever it is that they want as outcomes? And notice none of this is limited to dentistry. None of this is limited to medicine. It's, by the way, my thinking is there is no such thing as dentistry separate from medicine. Dentistry is just part of medicine. So in our common language, we talk about medical things and dental things, but in our approach to our patients, I hope that we're trending towards thinking about medical things, and the dental parts of it are just another subset that we have to guard against siloing and break down the barriers that exist currently between us because in part of language. So I may confuse you with my terminology because of that's how I think. Why do people have obstructive sleep apnea? What that phenotype, that label that we can put on somebody that has a diagnosis of obstructive sleep apnea? Well, years ago, some scientists down in Australia and also in Boston came up with this chart. And they said that 100% of people that have obstructive sleep apnea have impaired anatomy. 100%. Every single person. Now, we as dentists think immediately maybe of a narrow palate and a high vaulted arch and those kind of things. But that also includes a, a nose that doesn't work. It includes obesity that impacts the upper airway. So there's compromises to anatomy that aren't just bony structure. And that helps by keeping that in mind. We also think, okay, there's got to be more than what a simple solution. It's not just about expanding the palate, for example. There's also a breakdown of those 100% of people in about 3 different categories and pretty evenly distributed. And some people have more than one of these things. And ineffective upper airway dilator muscles. They've proven that when we're breathing while we're awake, that the genioglossus muscle resists the negative pressure of the oral pharynx that's caused by expanding the diaphragm, and that resistance keeps the airway open. And for a lot of people, it works at nighttime. For some people, significant, too many people, the genioglossus muscle doesn't work well enough at nighttime and the tongue falls back into the throat. Well, that's an ineffective upper airway dilator muscles, and there's a number of those muscles that are involved. And so, what we think about when we consider these things is that an impaired anatomy or an ineffective upper airway dilator muscles, it limits gas exchange because it reduces the amount of clean, fresh air that gets into the pulmonary system that gives the alveoli and the blood system a chance to improve SpO2 and eliminate CO2. So that limits gas exchange. Now, there are two other endotypes under the phenotype of obstructive sleep apnea that have a lot to do with CO2 sensitivity. Now, our respiratory drive comes from the levels of carbon dioxide in our blood, and there's chemosensors in several different parts of our body that send the signal to the autonomic nervous system to regulate our respiration. Those two that we're not going to talk too much about tonight have to do with how the brain senses that CO2 level and how it responds. So those have a lot to do with autonomic nervous system balance. And in my world, it's a fascinating amount of learning about those things, but that's not something that dentistry gets a chance to impact very much later in life. Now, I am quite intrigued by the concept that a young person, a little infant who can't breathe very well, their brains develop to have an heightened sense of CO2. In other words, they're going to respond quicker because they're desperately trying to stay awake when their brains are being formed. And so I'm checking that out with a neurologist, and I'm curious. When we consider the data that we're given by diagnosis, we are given things like apnea-hypopnea index. I'm going to come to that in a minute. We're given several different measurements that we can use for our patients, several different kinds of different things that we can study. But we're finding out that those don't predict dental device effectiveness very well. They don't predict symptoms very well. They don't predict outcomes very well. They just give us labels to put on them. Other things that are related to that CO2 balance are more helpful for whether a dental device is going to be effective or not. And so what that means is we have to know which data to pay attention to, which one gives us a profile that we can make a medical decision about and help our patients with expectations. We don't get to guarantee results in CPAPs. We don't get to guarantee results in oral appliances. We don't get to guarantee results in most anything that requires the patient to cooperate, because even though a CPAP will fix the AHI nearly every time, if they don't use it, it doesn't fix anything. So we have this variable outcome based on cooperation by the patient as well as what we started with in terms of data. Christopher Lettieri, a very important physician in our world here, said to the American Academy of Dental Sleep Medicine a few years ago that really, when it boils down to it, oral appliances, positive air pressure have pretty similar efficacies. They treat the patient about the same. There's not a ton of difference. There's not enough difference to really draw the lines there. But really, the best treatment for any kind of breathing problem is the one the patient will actually use. So it comes down to patient selection. It comes down to how well do we know our patient? How well can we apply our knowledge? How well can we use the knowledge base that we know already? And what are we comfortable providing? So the best treatment is the one the patient will actually use. So shout out to Dave McCarty, also on this call right now, because he has this wonderful little illustration that comes out of the book Empowered Sleep Apnea, and it's a great way for you to understand what's going on here. We have two terms that are thrown around a lot, apneas and hypopneas. And I know you guys are probably all up on what these words mean, but I listened to Dave explain this the other day and I thought, well, this is fantastic. And so, Dave, my apologies for my interpretation of what you had to say here. So obstructive apneas, look at the squiggly lines there. Notice that there's effort. Well, what do we do to breathe? We expand our chest, we move our diaphragm. When we do those correctly and we have an open airway, our lungs fill with air. When we relax those muscles, the elasticity of our tissues pushes the air back out and we're ready for another intake. Well, effort can be measured by elastic bands around the chest and around the belly that can measure the fact that we're trying to breathe. Now, we can also measure airflow. We have little sensors we can put under the nostrils so we can measure airflow, so we can know if the air is actually moving or not. When we couple a measurement of effort and an airflow, we can describe the various conditions that we have. If there are up and down lines on airflow and effort, we have normal breathing. When airflow stops, but effort continues, we have an obstructive apnea, which means we're trying to breathe, but we can't move any air because something's plugged up. If there's no effort and there's no airflow, that means the body is not trying to breathe. There's no movement of the diaphragm or chest wall, and that means that there's a disruption in the autonomic signal to that system to even try and fill the lungs. Now, when I was a young dentist in this area, they said, well, Steve, if they have central apneas, you can't help them because all you can do is open the airway. And that means that, it doesn't matter if they're not trying to breathe, you're not going to help them with opening the airway. We don't even know if it's closed during centrals, which is true. So don't bother if you have a patient with lots of centrals. Well, what we've discovered over time is that centrals happen to everybody all the time. When we pause our breathing long enough, that's a central apnea. When we have enough of those, it disrupts our autonomic nervous balance and reprograms our system. When we close the airway with apnea events too much of the time, in certain individuals, they will gain more centrals just because their system says, I'm tired of fighting this fight. I'm not going to even try and breathe now. If the airway isn't going to cooperate, I'm not either. I'm not going to move the diaphragm. And so what we have is a mixed apnea situation where there's a combination of closure apneas, obstructions, and no effort apneas, centrals. And we can just see that on sleep tests when we have the right signals coming to us as measurements. We also have hypopneas. Now, hypopnea has several different definitions. It's not important that you know all the different definitions, but what we want to think about there is a restriction in airflow. So if you're breathing air in and out, but then you pinch off part of that airway, then you're not going to be able to fill the lungs the same way because there's less area to move the air through. And we can have a limitation in flow. Think about it like the common metaphor is a milkshake. If you have a milkshake and you can bring the milkshake into your mouth with a normal sized straw, you're doing fine. Put too small of a straw in and the milkshake doesn't flow. Put a bigger straw in and now you can have an easier time of it. Well, a hypopnea is like putting in too small of a straw. So you have the same effort, but sometimes even the effort gets bigger as the body struggles to fill the lungs. But we have this chopping off of the airflow. You can see the flat spots on the tops of those curves because the air can only flow so fast when there's a minimal space available. We can have central hypopneas, which means just a little less movement of the diaphragm and chest wall. So we have less effort there. That's a puzzling one to treat because there's still moving air. And then we have another thing that's challenging for us in diagnosis called respiratory effort related arousals, which means we have to be able to measure the brain. The only way to measure arousal, which is a brain indication of a change in the brain wave activities, is to have electrodes on the skull, and so we can measure brain responses. This is not commonly done at home. It's becoming more commonly done at home because there are some ways to do that right now, and the sleep scientists are working on ways to make that available because it does give us a great insight into how the body is responding to different triggers in their environment, including obstructive apneas and obstructive hypopneas. So we're learning a lot more about this, but this gives you the framework for this. And one of the problems that we have as physiologists is that the definitions were created as time-limited events. In other words, it had to be 10 seconds, but there was no upper limit on how long an apnea would last. Once it was 10 seconds, it became an event count. Yay, they stopped breathing for 10 seconds. We can check the box. There's an apnea event. My father had AHI, apnea hypopnea index, a count I'll show you on the next slide, of 62. His longest apnea event was 97 seconds, which means he was trying to breathe for 97 seconds and couldn't move any air. Well, that's not a restful sleep period. And he had a bunch of those through the nighttime. So we have different ways of diagnosing our patients, but we have sometimes limited ways of describing what we're observing. When they came up with this idea years ago, measuring 10-second or longer events, then they decided, well, let's count those up and we'll divide by the time of the test. And when we, time of sleep is what they did actually, because they had brainwave activities. They knew when people were sleeping. And they came up with an index called a apnea-hypopnea index. This is an important number. We are learning that there are many other important numbers to pay attention to, but this is still an important number. And you need to understand that this number is going to be reported for everybody who goes through a sleep study. And that's common language for us. And now, as we learn more about how to describe the physiologic responses, then we will have more numbers to associate with this, but there will always be an AHI number reported. And confusingly, hypopneas can be reported at two different levels. I'm not going to get into the details of that because it's not critical for what you're trying to do for your patients these days. But understand that when you do see a sleep study, there are different ways to describe the data that comes off of those studies. One of the things I think I pay a lot of attention to is the oxygen desaturation index, because what happens now is the level of oxygen that goes to the brain has a lot to do with long-term physiologic health. If we have a patient who we can measure at SpO2, the simple measurement off of fingertip or some other body part that tells us the concentration of oxygen that's on the hemoglobin, if we can see that fluctuating up and down quite a bit, then we know that that physiology is also having to respond to changes in gas mix balance. And it's not easy for us to measure CO2 in the home. It's possible, it's not very easy, but what's super easy and reliable to measure SpO2. So as we are able to um, describe again our patient's body's response, then ODI is pretty valuable for us to look at. Again, there's no one number that we can point to, but this is a pretty good number to pay attention to. If we make a difference in this one, then we can have confidence that our therapy is actually doing something to help our patients, which means they come in to see us and they've had a sleep test and they want to get this fixed for whatever reasons they want to get it fixed for, and we want to get it fixed because we don't like the numbers, and we send them home with a device, or we give them an exercise, or we help them with nasal clearing, or we get them to not sleep on their back, or whatever therapy that we've described, that we've prescribed for them and coached them to use. And they come back and they say, Doc, I think I'm better. Well, we can we probably do need to do at some point another complicated sleep test, but we might want to do just a simple oxygen test to see if we've made any difference because we have a baseline to measure against. And how simple and cheap and easy is this to send them home with an overnight pulse oximeter and tells us whether we're making progress or not. And that's a good place for us to be when we're helping coach our patients through something that's not going to be a discrete, oh yeah, here's your fix. You just do that and you'll be okay. That's not how it works. I mentioned a while ago low arousal threshold. What this means is that our brains respond to changes to our CO2 balance. And we have a complex system in our brains called ventilatory drive. It's way too complex to explain to you right now. It's not really important for that, but just know that our brains are sending the signals through the autonomic nervous system to the parts of our bodies that breathe for us. And if we disrupt the gas balance enough, then we have an arousal. The brain says, wait a minute, I got to pay more attention right now to make sure I stay alive. And that the lower the arousal threshold, the more it intersects with ventilatory drive, the more trouble the patient's in to maintain a healthy level of normal breathing. So that low arousal threshold represents somebody who is a light sleeper, somebody who says, I can't get a refreshing night's sleep, who wakes up tired all the time. That's suspicious of a low arousal threshold. Then some other really fascinating work was done by this similar group. And they said, well, let's look at all the sleep studies that we know about. And when they were looking at this arousal threshold problem, they also were able to see a different level of filtering. And they found that the percentage of hypopneas and apneas was important. If we have mostly hypopneas in their study, greater than 58% of the event counts were hypopneas. And they also found that if the oxygen went up and down, but it didn't go down too far, their nadir wasn't all that low. And if they weren't obese, then they could see a pattern of CPAP compliance. Now, I'm introducing a couple of subjects there. One is looking at the granular details and also what are people going to be able to use. And it turns out that if any two of those granular details are true, that predicts low positive airway pressure adherence. So now you have your patient in a room and you're talking to them about what they're willing to do, and you're looking at their sleep study, and you realize that they fit two of these categories. And you're helping to make the decision for them or the recommendation for what they should embark upon them for a course of therapy. If you see these two of these items, you might think, you know what? Why don't we try that positional therapy? Why don't we try this oral appliance? It doesn't really matter how big the number is for the AHI. What it matters is what's the details. So these are the kinds of things that we're learning about how to break down our patient's diagnostic process or outcomes and help to apply precision medicine and meet them where they are. In fact, Dr. McCarty came up with a wonderful construct in empowered sleep apnea called the 5 reasons to treat. I use this every single day in my practice because it helps me connect patients with the reasons why they should do anything to match up their felt need with what I've diagnosed. And so one of the risks is cardiovascular risk. And that is the big scary one. Risk is difficult to talk about, so we have to find something that connects in their life. Many patients have a history in their family somewhere of cardiovascular risk. One of my patients, a very memorable patient, he was 36 years old when I met him, and his aspirations were to live past 40. Because if he did, he was going to be the first male in generations to live that old. And he's 36. So he's quite worried. And why? Because they had cardiovascular disease in their family. And I know you guys have studied with Bale and Doneen, and so we know quite a bit more about why he might be at risk. That's not important tonight. But this young guy wanted to make sure he was going to wake up the next morning and he knew that getting sleep apnea treated was a big part of that. So I was helpful for him to not only treat his sleep apnea, but also to give him quite a bit more confidence. So one way you can explain cardiovascular risk is this. We have this part of our body called we call it a thorax. Other people call it a chest cavity. And we have a heart in the middle of that, of course. And we have only really three good ways of resolving the negative pressure that happens when we expand the thorax. Primarily, we resolve that negative pressure by having an open airway and air flows in and fills the lungs and the pressure normalizes. But what if the airway's closed? What if we have an apnea? That leaves us with two other ways to resolve that negative pressure. One of them is the stomach. And so we have an esophagus running through there. And if we have a big negative pressure in the thorax, then we pull stomach contents up against the lower esophageal sphincter over and over and over again over time. Or if we have a weak esophageal sphincter, we get stomach acid contents where they don't belong in the lower esophagus, heartburn, Barrett's esophagus, other bad things can happen. But we're talking about cardiovascular risk. So what happens here? If the great vessels are now responsible for resolving that negative pressure, we pull more blood into the heart. And the first place it gets to is the right atrium. Well, the right atrium is a thin-walled structure. It's designed to just shunt the blood into the right ventricle. But embedded in the walls of the right atrium is a sinoatrial node, which controls heart rhythm. If we stretch that over and over and over again with susceptible individuals, we end up with atrial fibrillation because the heart loses its ability to regulate its own rate. If once that extra blood leaves the right atrium, it overfills the right ventricle. Another kind of small or thin-walled portion of the heart, because its job is just to send blood in a normotensive way to the lungs. So it doesn't have to work real hard. Well, and it's not very far. And so that thin-walled muscle can expand with this overfilling of the blood that's pulled into the negative pressure, and we end up with an enlarged heart, a cardiomyopathy. The blood goes into the lungs, comes back into the left atrium. Now we have more blood volume coming into the left atrium, which stretches that, and there's also some sensors nearby the left atrium, and that stimulates something called atrial natriuretic peptide. What does that mean? That means that's a signal that goes to the kidneys that says to the kidneys, wait a minute, we have too much blood volume here. So let's regulate that. Let's reduce blood volume. What do the kidneys do? They do their job, and they pull liquid out of the blood system and put it into the bladder. So what happens then? We have nocturia. We have repeated trips to the bathroom. We have enuresis in kids. We have these kind of things are happening because we have too much blood giving too many signals to the left atrium. Now we have the big problem because now we have all this extra blood flowing into the left ventricle. What is the left ventricle's job? Pump it through the whole rest of the body, including the brain. And what is the left atrium pumping now? We're pumping extra blood volume because of the kidney function. The blood is thicker, and because the airway is closed, we have less oxygen available in that blood. So we have a heavy muscled wall of the heart working hard to pump blood out of a negative pressure zone with less oxygen available. This is a recipe for a heart attack. So that's the cardiovascular consequences of having a closed airway. And you can sketch that out and deal with that in a couple of minutes with your patients, and it really helps them connect why bad breathing is a risk and why they want to protect their heart. They got to make sure their airway stays open. Another one of the reasons to treat is snoring, a big reason. Tons of people have sleep divorce because they just can't bear the noise in the bedroom. They avoid social opportunities. They don't go on trips. They get razzed while they're on a trip because of snoring. So snoring by itself, there's some medical consequences of snoring that we know about too, but socially, it's enough. That's enough of a reason to fix this once the patient complains of snoring and we have a diagnosed disease. So this one.
Chief Medical Editor, Dr. Nancy Snyderman.
Are you kidding me? It's fodder for jokes in movies and on TV, and can be a bedroom annoyance.
If I don't fall asleep before him, I'm not going to fall asleep. I give him a shove.
You need to wake him up or turn him over or something just so that you can sleep.
But new research shows snoring should not be ignored, and in fact may be an indicator of cardiac disease, the #1 killer in America. For the first time, doctors say snoring alone may be an early sign of heart disease, likening it to other well-known risk factors like sleep apnea, obesity, smoking, and high cholesterol.
We wanted to kind of bring to light the fact that snoring may in fact lead to adverse health.
Researchers at the Henry Ford Hospital and University of Nebraska measured the thickness of the carotid artery, the major blood vessel in the head and neck. They found those who snored, regardless of other risk factors for heart disease, had significantly greater thickening of those blood vessels. And that thickening is associated with an increased risk of heart disease or stroke.
Snoring in terms of risk factors was #1 independent of the other risk factors, and also was more likely to lead to that thickening than the other, quote, traditional risk factors.
Snoring is a telltale sign that a person's airway is being partially blocked. Experts say the vibrations and strain that occur in the airway can also put pressure on blood vessels in the head and neck. Over time, those critical blood vessels narrow, making it harder to pump blood into the head and brain and putting, in turn, undue stress on the hearts. So for all of you snorers out there,
it's like an elephant,
like a buzzsaw.
The earthquake that we had a few years ago.
Consider this a wake-up call. Snoring is not just a joke. It's now a reason to go see the doctor. Dr. Nancy Snyderman, NBC News, New York.
So it's not just about social either. Now, this is an interesting study. What they found here, this is the atherosclerosis study. Another study showed that the bed partners of successfully treated snorers had lowered blood pressure and a higher quality of life. So there's a lot of things going on with just snoring. Don't let any of your patients dismiss that as a benign problem. They may not have been told that before. Poor quality sleep. So, what goes on while you're sleeping is a reason to treat. And many people know that they have poor quality sleep. They feel it. They don't wake feeling refreshed. They tell you that they're terrible sleepers. Well, explore that with them. What does that mean to them? What does terrible sleep have to do with anything for them? And what we know also that happens during sleep is we influence our physiology. If we have a poor quality sleep, we're not breathing well, we have sleep apnea, we have pressure changes in the upper airway during sleep. While the bones are growing in single digit age years, that poor quality breathing influence the bone growth. By the time that the bones finish growing, but the brain's not mature yet, we have limbic system disruptions. And by the time the person has dealt with these disruptions for decades, we have chronic disease. And that's just the biggest thing that goes on is over time is we have to think differently about the impact on our patients. So, what goes on during wakefulness? Well, most of the time, people complain about being extra sleepy. They can't make it through their day. They have brain fog. They have some other things that are worse because during the daytime, when they can perceive lots of things about their bodies, about how they're making it through the day, they can be extra. They know that they're drowsy driving. This is what got my dad to get treated. Is he called me one day and he said, Steve, he said, tell me about that sleep apnea stuff. I said, Dad, I've been talking to you about this for 7 years, 6 years. Why now? Because he realized he was sleepy driving home from work every day from in Colorado. And I said, well, yeah, Dad, let's go get you treated. And so he ended up with a CPAP. He was happy about that. He felt he was more productive during his last 2 years of work. Yeah, gosh, I wish I'd done this earlier. And I said, well, Dad, let me remind you about the 6 years I've been telling you about this. The other thing that happens when people don't sleep well at nighttime is their brains are disrupted. I mentioned earlier that during the brain formative years, the brain finishing maturing years of young adulthood, we have a lot of complaints about depression and TMJ problems, chronic pain, fibromyalgia, IBS. All these things are coming along in these young adults. That's because their brains aren't mature yet, and yet they're being disrupted over and over and over again by bad breathing during sleep. But they feel it in the daytime. So your patients are in your practice and they're telling you about these things, and they tell you about their history of seeing multiple physicians about their complaints, and nobody has an answer. And everybody says, well, it must be this, and they try a treatment for this and it doesn't work. And you say, well, tell me about your sleep. Tell me about how you feel for sleep quality. And I go, well, I sleep terribly. And they think it's because of the chronic pain. And what we're learning in medicine about the chronic pain is connected to the poor sleep quality. You don't tell them that you're going to fix their sleep apnea and their chronic pain will go away, but you can say we can make a difference. When your patients complain about headaches and jaw pains and insomnia, it's all related to poor sleep quality and what the brain is stimulated to uh, to get out of its normal. I want to go back to homeostatic process tendencies. If we eliminate some of the disruptions to homeostasis, then the brain will heal itself. The sleep cycles will go back to normal, and we'll have better chance of resolving some of these other issues without necessarily addressing them as individual standalone problems. So if your patient is sleepy, but not, the traditionally old fat guy that has sleep apnea, so we have to think about what are they doing to help themselves. And sleep hygiene is a general term for the practices that we put together to make sure people can sleep well. And you ask them about, is it a good sleep environment? Are you, getting your nose clear at nighttime? Is it cold and dark or cool and dark where you're sleeping? And they say, oh yeah, I do all those things because I've read about that on the internet. I know what to do here. but we have these unexplained medical problems. And a few years ago, they came up with a term called functional somatic syndrome up at Stony Brook, and it really matches what we see, because homeostasis it could be my favorite word. If I ever get a tattoo, it might be homeostasis. And allostasis is the process our bodies go through when we challenge our bodies and make sure and disrupt homeostasis. Well, there's a process that's supposed to happen. And that is when we challenge our physics. For example, we go and exercise. We get hot and sweaty, don't we? Why? Because our muscles are working. We're burning lots of oxygen. We're making a lot of heat. That's okay. We have capacity for that, because what happens later is we return to homeostasis as we cool down. That's fine. That's a challenge, a response, and a reset. Our body temperature is a certain amount, we get hot, and then we get cool back to normal again. That's ordinary. We do this every day. And this process happens in lots of bits of physiology. If we that's called an acute allostatic challenge. We can also adapt, which means that if I go and challenge my muscles at the gym and I lift weights, and I can get stronger there. And so now my weightlifting capacity goes up. That's called conditioning. So I can respond differently later when it's time to lift more weights. And again, this can be applied across lots of parts of physiology. However, if we have a chronic problem, and we, instead of accommodating to it, instead of adapting to it, instead of gaining a new level of physiologic response, we actually end up stimulating a negative response, a disruption to homeostasis. That's when our functional somatic syndromes kick in. So the HPA axis, hypothalamus, pituitary, and adrenal axis, kicks out more irritating or inflammatory cytokines, inflammatory producing chemicals. We have more disruptions to what we should be feeling normal. And that another way to say this is, if we have a acute allostatic challenge, it creates a response. But a perpetuating allostatic challenge, something that happens over and over and over again, can sensitize the limbic system. And we increase our cortisol, and we increase our stress hormones. And so then that gives us a lower arousal threshold. It gives us a different body response than our bodies are ready for. I'm going to skip that. And some of the mechanism comes from an unexpected source. When I was taught anatomy, they told me that, well, cranial nerve 1 is olfactory. That means that you get to sense what's in your environment, and you can smell the pretty roses and the garbage stench. I mean, it tells you what your environment is like, and that's about what it does. The test for whether cranial nerve 1 is functioning properly is, can you smell this vanilla bean? Can you smell this smelling salts? That kind of thing. You know, that's what it was. But what we've learned since then is that cranial nerve 1 also has connections to the limbic system, the part of our brains that has to do with our homeostatic balance. And if we are breathing well through our nose, then there are temperature sensors and also some mechanical receptors that send a regular pattern of signals to the limbic system. And if we don't breathe through our nose, they don't get those pattern signals. And the limbic system, being the center part of our brain that shuttles information between the cortex, where we make decisions, and the autonomic nervous system that controls our physiology, that limbic system has a ton to do with quality of life. It regulates our emotion. It gives us an ability to remember things. It helps us to balance how we respond to our everyday challenges. And so here's a kind of a fun illustration of that.
It's been a long day. Your head hits the pillow and you're out like a light. But inside your body, the workday has just begun. You see, when you sleep, red blood cells carry oxygen to the brain, organs, and body tissues, preparing all systems for go tomorrow. But if you snore often and loudly, it could be a sign that your airway is closing and your breathing is being continually interrupted, shutting off your intake of oxygen. Snoring can be a symptom of a more serious condition called obstructive sleep apnea, or OSA, in which the upper airway collapses repeatedly during sleep, shutting off your air supply, like a kink in a garden hose shuts off the flow of water. The result is that your breathing can stop for 10 seconds or more, literally dozens of times per hour or hundreds of times per night. This deprives your brain and body of the oxygen they need to restore themselves overnight. It also allows carbon dioxide to build up in the bloodstream, which causes painful morning headaches. This interrupted sleep pattern leads to waking up feeling exhausted, like you ran a marathon in your sleep, as well as irritability, difficulty concentrating, and, where was I? Oh yeah, daytime sleepiness. As blood oxygen levels drop, your brain and body go into survival mode, also known as fight or flight. Buckets of adrenaline are dumped into your system, raising your blood pressure and heart rate, causing your heart to beat more forcefully and rapidly. This is helpful when facing a woolly mammoth, but not so good when your body is supposed to be resting. Adrenaline also jump-starts your inflammatory cell response and makes the blood more likely to clot. Again, good if you're wounded in a fight, but not good if you are sleeping. The risk of clotting and inflammation in the blood vessels makes heart disease and blocked arteries significantly more likely. Your body also floods with cortisol, a hormone which stimulates the appetite and increases blood sugar. Together with surging adrenaline, the sustained release of cortisol can lead to weight gain and diabetes. When this happens night after night, it increases your risk of a heart attack, stroke, or heart failure. It can also lead to decreased libido.
Wait, what?
Restful, uninterrupted sleep is vital to your health and the single most important factor in maintaining a healthy brain and body. In fact, studies now show that people with untreated sleep apnea are more likely to get dementia and Alzheimer's disease as they age. But when sleep apnea is detected and treated, you'll greatly improve your sleep-breathing health, and you'll feel better almost immediately. You'll be more alert, more productive, with more energy and an overall higher quality of life. The crucial first step is to understand your sleep-breathing health and what it can tell you about the risks your body may be taking during sleep.
So these kind of little cartoons are handy to give you some language to talk to your patients about, to show them in your office, different ways you can communicate these things with your patients. So another reason to treat is comorbidities. This is one of the easier ones to discuss because people have been to the physician's office and they understand they have these troubles, and you can start to show them the connections between cardiovascular disease, from insulin resistance, diabetes, non-alcoholic fatty liver disease, several other things that are highly connected with breathing problems at nighttime and disruptions to homeostasis. And so you have comorbidities as one of the things that you can add to the reasons why they need to treat. This little graphic has been around a while, and you don't need to read the words in those little white boxes because you don't want any of the things that are happening in any of those little white boxes. They're all bad for you. You don't want any of them. I picked out a few of them that are just kind of interesting, but if you look into some of those things, then you'll realize that there is no part of the body that's untouched, unaffected, that's allowed to be separate from bad breathing episodes called obstructive sleep apnea. This real study was done in Denmark, and what they looked at here was they looked at children's healthcare costs. It's about money. And they looked at this many kids, a lot of kids, and 2 years prior to adenotonsillectomy and 2 years post adenotonsillectomy, the median healthcare costs went down by a third, by 37%. Antibiotic costs went down by 2/3. Office visit costs down by this is about the money. But think about the family disruptions, because if you need to have a lot of antibiotics for your kid, that means they're having a lot of infections. And to get to the antibiotics, you have to get to the office. That means you have to take your sick kid to the office. Well, that disrupts your family. You have to pay for the medications. You have to deal with giving the child medications, and they're not feeling well. And then you repeat that over and over again if you don't get to the heart of the problem. Now, this is not a story about doing AT surgery, but what it is it just illustrates that even if all we think about is the money, but we have to extrapolate that into the impact on the family for what we should do. Because really, we got to consider that breathing and airway support is really part of everyday practice. It impacts every part of your patient's body systems. It impacts their whole life. And when we learn what's going on and we can connect them with 5 reasons to treat, then we can get people to take action to make themselves better. And when they come back to you and they say, wow, not only am I not snoring, but I feel great. I'm dreaming again, and I'm confident that I'm protecting my heart. My dad got a CPAP machine. He told me, Steve, he said, I'm more productive at work. I can stay awake in meetings. I feel like I'm a much better team member than I was before. I mean, those are powerful statements that we can have for this. So what do you do with this information? Take what you can, take what caught your ear, take the language that you heard, take the messages, the ability you have to communicate, and connect with your patients. Again, Dr. Pankey said, get to know your patients and know your work before you apply your knowledge. And that means you have to screen every patient. You have to look for the problems. It can be a simple screener like stop bang or I'm sleepy for children. You have to stay curious. And that takes discipline. And I think the people on this call have that discipline. Otherwise, you wouldn't be curious to be on this call. But be curious about your patients. Stay in the question, according to Mary Osborne. You want to ask more things about what they just said. Help them explore what they may not be totally aware of in their life. Help them discover what their high perceived benefit is. And always consider the breath as a vital sign. It's something that we have to think about all the time. It's not just blood pressure, oxygen levels, pulse rate. It's about how they breathe. And that's going to be a critical data point because really, we're all part of primary care. There's not a separation between medicine and dentistry. Our primary care trained physician colleagues know more than we know about some things. We know more than they know about some things. Together, we know a lot about how we can address our patients. And our primary care colleagues are overburdened. They have minutes to see a patient. So what does that mean? They pay attention to acute needs. And we can add our proactive interventions to their acute needs, and together with our patients, we can make a real difference. Because this truly is a thinking person's game. My friend Kevin said this while we were lecturing together years ago. I'm still putting his name on it, but I'm going to take that off pretty soon because that's such a powerful statement that he doesn't own that. This is something we all have to embrace. As you deal with your patients, the kinds of things that you're trained to see, I want you to consider expanding that. You guys all do this already, but our colleagues, our whole professions, the professions of primary care, the professions of sleep medicine, the professions of dentistry, hygiene, all of us, we need to expand our thinking and consider that, in fact, when we see a patient, we have to be curious. We have to think about it. We have to take all the data and put it all together for our patients because it is a thinking person's game. So here's a few of very many great resources. You probably heard of all of these already. If you have a new family in your practice, instead of sending them some candy or flowers or just a card, if they have kids, send them a copy of Dr. Lim's Breathe, Sleep, Thrive or Dr. Maple's Brave Parent. If you have a family that's struggling with children that are working through the behavioral issues of diagnosed or undiagnosed breathing problems, give them a copy of Sharon Moore's Sleep Wreck Kids. The families will love you for being impactful and how they can help make decisions. And these other books are fantastic. I've mentioned Empower Sleep Apnea. Patrick McCowan is well known to many of us, and The Breathing Cure is a big book of, it's an encyclopedia of all the things that we can do. He's got a brand new book out now called The Breathing Cure for Sleep Apnea. I just ordered it today, so we'll see what that looks like. To learn more, well, you got a great resource here with Dr. Pritchard and Dr. Wilkerson and Laura. Of course, these are fantastic educators here. But the American Academy of Physiologic Medicine and Dentistry, probably a lot of you are members of that. We do webinars all the time. We have 2 great webinars coming up in the rest of this month. The American Academy of Dental Sleep Medicine has a good training program. And now what they do is they allow you to gain a certification or a designation. You can become a qualified dentist, is what they call it. You can also become a diplomate. I'm a diplomate. And what that means is you've committed to a lot of education. You've committed to learning about a bunch of stuff. Now, in your communities, if you have physicians that are used to credentials, then you can say, well, I'm a qualified dentist. Now, you have to tell them what that means, but you can at least say it brands you as being someone who really wants to learn more. Because you don't go through those programs and get those qualifications. You don't get those masteries without committing a great deal of resources to that and resources of learning. So that's something that you can use to differentiate yourself in your community or make sure that other doctors that you work with are up to, they understand what you're interested in doing. We're having a great program coming up in Fort Lauderdale later actually in a couple months, called Airway Palooza. A fantastic program down there. Bunches of experts are going to be there, and since we're not talking all the time, we're in the audience, and we're in the breaks, and we're in lunches, and so you can ask questions from, any of a number of disciplines there: physicians, hygienists, myofunctional therapy, physical therapists, all kinds of people are going to be there to talk to you. And there's some codes there if you want to use those to gain some discounts on getting signed up for that. So that's what I have for you guys. Gina, Laura, that's it. Let me stop my sharing.
That's it. I don't know about
Yeah,
all of you,
that's
but
everything I know.
I don't know.
Christy Ball is just here just now. Great.
This was absolutely amazing. And I do want to open up for questions because just so much grateful information. I have so many takeaways, but I do have to lead with the tattoo. I will personally love to see your tattoo of homeostasis. So I hope you'll get one of those. But takeaways, Dr. Dave, thank you. I think just the 5 reasons you going through that, Dr. Steve of his is so impactful because those are things we can do, right? Anybody can go in tomorrow and go just talk through those 5 reasons yourself with patients. Even if you said, I'm going to do one of them, I'm going to do 2. And every day we kind of work through, just love those takeaways. I was opened up to the any 2. I like the little check, like, hey, I could work with this patient in some other areas. I haven't seen that. I thought that was really applicable. Loved your little heart with the box. Can't wait to hear Dr. Gina's take on that. But really kind of put it together, I think, visually for a lot of people. So love, love, love so much. I do have a lot of people, though, asking. I want you to be able to peek in the chat. I'm going to read these to you.
Yeah.
Dr. Steve, one of the big ones that kept coming over was about your videos. Everyone was just blown away with those. Can they get those anywhere? How could they see those again, besides here?
Sure. I'll tell you what I'll do, Laura, is I have a Dropbox where I've stashed all of those, and I will send you a link to that Dropbox, and people are free to use those. These are the ones I've collected over the years from different manufacturers or YouTube, the NBC News ones from YouTube. But there's a lot of those little pieces that you can put on an iPad, or you can have for meaningful conversations in your treatment rooms. So if you have a patient waiting on something, your team members, instead of engaging them about, their vacation or about the weather, which, of course is important for relationship building, you can also make it about health. You can involve them with your commitment to health. and that differentiates you and it gives them an opportunity to say, oh yeah, I was thinking about that. What do you think about? And I'm curious about, and I read about. I mean, it just opens the conversation for something important to talk about. So those little videos are handy that way.
Perfect. And again, they asked about the cartoons. I didn't know who those were from, if those were from
Oh,
Dr. Dave or.
no, that's Dr. McCarty. Yeah, Dave is our cartoonist in residence here. He's going to be the one that can communicate best with the lovely cartoons, right, Dave?
Yes, sir. And many of your cartoons were other people's work, I noticed, but and I love it. But yes, cartooning is a bit of what I do. So thank you very much for showcasing that, Steve. It's a wonderful way to reach out with this message. It's a very humanizing way to talk about this. So thank you.
And there's a question there about the books. The best resource I put for the children's airway, I put together a sheet that has book covers and QR codes for where you can order them, and I will forward that to you, and you can forward that along to anybody also, Laura.
Perfect.
Awesome. I put a link to the 5 Reasons Monument on the Empowered Sleep Apnea website, which brings you to the place that you can sort of scroll through the 5 reasons to treat with the cartoons. So in case anyone's interested, thank you.
I see some other books. It makes me curious about all these other books too. Janet Madrid has a book, and I'm sure there's several others mentioned here that I saw. So cool. Yeah, we're all trying to make the communications better, right? Dr. Lederhausen.
So if you have more questions, drop them in there. I do have a question. I think a lot of, and I'm going to speak from hygiene world. I know we have myofunctional therapists, people on here, but I would love to hear from you. I think one of the biggest struggles sometimes is with children, even though related to behavior issues, related to anatomy. What do you feel is one of the best ways? Going through the 5 reasons? I know we could that tool, but what would you say just to start being able to open that conversation with parents?
The very best thing for a dental professional to use is the Fairest 6. And the Fairest 6 plus 4 is actually even it adds a few more things. We are trained as dental professionals to complete the Fairest 6. It's not something that a school nurse can do, for example, but a dental professional or a medical professional is paying attention to this can do that. And Samantha Weaver, well known to many of us, has done a fabulous YouTube of the Ferris 6. And so I'd refer people to that one. I think that's going to be the best way to answer that question, Laura.
Perfect. And just able to use that, I think is important. I know a lot of times people just struggle with that because, right, they're being told maybe their orthodontist or somebody else previously said, oh, just wait. So just love hearing that and having that resource for our community.
I've put a link to the Ferris 6 plus 4 PDF tool into the chat for everybody.
Well, there you go.
Dr. Gina, I'm going to let you. Do you have a question?
Well, I have a comment on why is this the first time that I've ever heard about describing evaluation of breathing or breath as a vital sign? Why hasn't it been on the list of vital signs forever? I mean, we count the breathing, and of course, in the critical care unit, we run down the hall. If the O2 sat goes below 98, it can make the difference in, life and death if it continues to go down, or the difference in someone making it through a procedure or getting through the pain or whatever. But then we send them home and kind of don't give it another thought. So thank you for that. I think it's a great way to describe to patients, you're watching your blood pressure, you're watching your heart rate. Let's talk about breathing, not just your rate, but the oxygen level. Yeah.
And a pattern too, Dr. Pritchard, because when we think about what like Patrick McCowan has taught us about how they breathe, well, we've known for thousands of years through yoga breathing. Now we're getting science behind some of that too, because we can see brain patterns emerge when we have certain breathing patterns, and brain patterns disappear when we have others. And so we are noting the effect on physiology by how and which portal we use to breathe through. I want to take advantage of that. It's not just that, do they breathe 12 times a minute or 20 times a minute or 6 times a minute, but do they look like they struggle? Does it look like they're suffering from air hunger? Can we change that rate and help them with their CO2 sensitivities, kind of things that Patrick has taught us to pay attention to. Yeah.
Yes. So good. Thank you.
Well, I'm going to add in saliva testing. We got a lot of saliva testers on here tonight. And to me, just people ask all the time, as a saliva hacker, they're like, why can't I get rid of Tannerilla forsythia? It's not the only one, but it is a very common one of the first red complex to show up. And we know there's a direct correlation to these hypoxias, to just desaturations, that we get a shift in the oral microbiome. And so that's why I feel like just being able to screen our patients, like you're saying, Dr. Gina, knowing it's a vital sign, but asking, so many of us are looking for seeing signs of periodontal disease, gingivitis, and we should be asking, I always say, where's the root cause? Is this a breathing issue? And we're actually not screening for it. But I know that's why everybody's here tonight. And so I do have to give a shout out to all my saliva testers. Just connect the dots. Don't miss this. Don't miss why getting these red complex, and asking why, when they're, especially they have good, I'm going to say, oral hygiene. A lot of people keep saying, I don't understand. And everything you're talking about tonight just brings the whole oral systemic connection together. So I just have to give that shout out. But I could watch this probably 5 more times, Dr. Steve, and get so much really crucial information for our patients, for the connections that we talk about. So appreciate that. Any last questions on there? Dr. Jan, do you see anything else come in?
I don't. Everyone's appreciative of the information that Dave is sharing. Thank you for
Yeah.
that, Dave, in the chat. And yeah, I don't see any other new questions coming in though, but I agree with you. I'm going to watch this again, probably more than once. Very valuable. So helpful, Dr. Christensen. Thank you. Carstensen.
Steve, remember Gina, Steve.
Okay,
Steve
Steve.
worked.
Thank
Yes.
you, Steve.
Well, I appreciate the honor of being invited. It's always good to get the message out to such willing learners, because I know that this some little part of it is going to show up in a patient, in a family's decision making, in a patient care situation, in a confidence to approach the next patient situation. And all of those things benefit our community, and that's what we're all about here. So it's fantastic.
For
Thanks,
sure.
guys.
And I would say one other quick question, because I think it's important. When is grinding a problem? It's always a problem, isn't it?
There you go.
Right. Yeah.
It's never not a problem.
Mhm.
And it's a sign. It's overuse of the muscles. It's a response to a brain interruption. We don't have great data about, like, some kind of randomized control trial that says a 6-year-old who grinds her teeth this is the cause and this is the downstream problems. We just know it's a big red flag warning sign. So let's figure out what else is going on that might be triggering this extra muscle activity. It's certainly not physiologic, So what's the disruption here? And look for that. So use it as a springboard for evaluation.
Excellent.
Well, appreciate everyone in our community. Thank you so much, Dr. Steve. Just so much great information, enlightening. And I hope we'll get feedback on the people using their 5 reasons. I hope you'll all going to challenge everyone to go do that. Also challenge you to go to the airway, the Palooza. It's on the beach here in Florida. So come visit us, right? And hope to see all your smiling faces. We will have our next study club. Remember, it's every other month. So we will see you in October, and have a great night. Thank you, everyone.